Thank you, Amber. The American Professional Society on the Abuse of Children. We are thrilled you are here for the week 3 of our prevention series. We have obviously, hopefully you all have joined the first 2. We are going to have our third on tertiary prevention with Dr. Cheryl Lanktree today. Before we get started, I'm going to quickly share a few ABSAC updates. Many of you are big supporters of ABSAC and are ABSAC members, but if you are not, we would love to have you. We are a membership society with members in all disciplines involved in prevention, intervention, and treatment. If you've not yet joined ABSAC, we encourage you to do so and take advantage of other membership benefits, including free and discounted trainings, free resources, no hit zone materials, and much, much more. We have tons and tons of online trainings and coming up in New Orleans, June 9th through 12th. We have our 31st annual colloquium. There'll be 13 tracks with many different workshop sessions, tons of New Orleans fun, including a second line through air-conditioned mall, much, much more. And we will go ahead and put in the chat a discount. To celebrate the eclipse, you can still get a discount to the colloquium. So we do hope you will join us. This will be recorded, and there'll be a quick question and answer at the end. And we'll also share Dr. Lanktree's email and contact information for you to follow up. So I will go ahead and introduce Dr. Lanktree. Dr. Cheryl Lanktree is a licensed clinical psychologist and research associate professor of psychiatry in the behavioral sciences at the Keck School of Medicine, University of Southern California. She graduated with a PhD in clinical psychology from the University of Manitoba and completed a pre-doctoral internship at Yale University and postdoctoral fellowship at Harbor-UCLA Medical Center. She's held academic appointments at a number of different universities and previously served as director, Miller Children's Abuse and Violence Intervention Center, and clinical director, Stewart House, Santa Monica UCLA Medical Center. She developed the evidence-based treatment model, integrative treatment of complex trauma for children, and co-developed integrative treatment of complex trauma for adolescents with grant support from Substance Abuse and Mental Health Services Administration. She currently co-directs the Center for Integrative Treatment of Complex Trauma, providing trainings and consultations on ITCT. She's published books, book chapters, and numerous articles related to the assessment and treatment of trauma in children and adolescents, and co-authored several treatment guides. So with that, we have a wonderful presentation, a perfect person to talk about tertiary prevention, and I will go ahead and pass it to you, Dr. Lanktree. Thank you so much for being here.
Thank you, Hannah, and thank you all for joining us today. This morning or afternoon, depending on where you are in the country. I am very, very happy to be here and to give you some thoughts on how we approach tertiary prevention through treatment, which will include also some assessment approaches and strategies, but focusing more on outcomes that we do see in encountering maltreatment in children and adolescents, and how we might be able to prevent further victimization for our clients, as well as down the road when they become adults. So let me go to the next slide. And we will have time at the end for Q&A, a few minutes. Once I get going, I tend to talk a lot, so I'll try to be mindful of the time, and so that we do have a little bit of time for discussion. If you want to include any questions in the chat box, that would be great. Okay, so when we think about the relationship of child maltreatment, which includes abuse and neglect, all forms of abuse, also witnessing intimate partner violence, all these forms of maltreatment, as well as disengaged parenting or disattunement with caretakers, we want to think about how subsequent abuse, long-term effects might be prevented. And so there are a few points that I want to cover here on the next few slides. Those maltreated in childhood are more likely to experience additional maltreatment, including physical and sexual assaults, as well as psychologically hurtful relationships in adolescence and adulthood. We know that this has been a reoccurring theme in the literature for number of years, going back to the 80s when we first started thinking about these things with work that Diana Russell did, David Finkelhorn. More recently, John Briere has published quite a bit in this area on self-trauma and how we can intervene earlier on to prevent some of these long-term effects with adults. The cumulative or interactive effects of stressors are thought to complicate and intensify post-traumatic outcomes. So I'm going to be throwing into the mix here complex trauma or complex PTSD, or others also call it other forms of complex trauma that, will encompass the long-term effects that occur that can go well beyond post-traumatic stress. So child sexual abuse, another study done by John and colleagues, John Briere, who is also the co-developer of our model integrative treatment of complex trauma for adolescents and young adults, found in this study with, it was quite a large sample of women who were recruited via internet recruitment procedures and answered an anonymous questionnaire, and also completed the trauma symptom inventory too, found that child sexual abuse at or before 13 years, as reported in this sample, doubles the risk of adolescent or adult sexual victimization. So when we think about trauma treatment, addressing and attempting to prevent these long-term effects as we encounter children and adolescents in our work, whether through forensic interviews, my past experience has involved working, I've had the honor of working with children's advocacy centers, both hospital-based, Stewart House in Santa Monica and Miller Children's Abuse and Violence Intervention Center in Long Beach. So we were able to get a lot of our referrals from the forensic team, but also from the hospital itself, from the emergency room, inpatient units, also from the community, including schools. So through these settings, we were also able to really provide a lot of interventions for the caregivers, which I feel is integral and crucial, especially with younger children. But I would say not to overlook the opportunities for interventions with caregivers, even with older adolescents and young adults, because thereby we are able to address multi-generational trauma, which is, I think, really central to preventing further victimization within families, but also to help families be protected from other sources of trauma that I will get into in a minute. Trauma processing within treatment also reduces the likelihood of risky behavior that can contribute to re-victimization. And we can, in these ways, facilitate empowerment, healing, and a sense of self-efficacy for kids of all ages. Affect regulation, capacity building within treatment, addressing safety interventions, improving safety, strategies, psychoeducation, self-esteem, identity validation. These are all aspects of treatment, whether it's an EBT such as trauma-focused CBT, or it's an EBT like integrative treatment of complex trauma, or other complex trauma intervention models that I'll mention later on. We are really, through treatment, even within a short time, even if it's 6 sessions, and that's all we have access to the child and family to be able to conduct a shorter amount of time, we can increase the capacity to prevent maltreatment, to facilitate resilience if maltreatment should occur, but to really prevent those long-standing, long-term effects, and reinforce self-reference. And of course, a strong therapeutic relationship, the general factor in treatment, regardless of whatever intervention or treatment model you use, having a strong therapeutic alliance and providing that empathic attunement through therapy provides opportunities for attachment, relational processing, which is a big part of our model, ITCT, but other models as well, such as ARC, which was developed on the East Coast. And these opportunities and being able to form a strong therapeutic alliance whereby the child and the family are being supported, but also challenged to think about things differently, but in an empathically attuned manner, can facilitate healthy functioning in other relationships. And I see this also in my private practice, where I focus these days mostly on older adolescents and adults. Okay, and then advocacy, of course, being a big part of APSEC as an organization, and within child maltreatment field and interagency collaborations. Again, another important aspect of our model, but other models as well, can increase safety, provide opportunities for the family to access services, and reduce risk of further victimization. You know, over the years, I've developed and supervised, directed programs for including the most recent program at USC, which was training focused and continues under the auspices of the Center for ITCT, which we are collaborating with folks at Children's Advocacy Services in St. Louis to continue this work through our consultations and trainings that we provide. We really encourage agencies and clinicians to think about case management within treatment as well, that it's not something that you're going to allocate to another individual, that this is also a way of fortifying the therapeutic relationship. If you are facilitating resources, perhaps you're facilitating getting them into safe housing, or say a child discloses something that hasn't previously been reported in the way of abuse or neglect, and you make that report, and then that triggers all the resources and services that can be provided, say, through child protection, then these collaborative relationships are really telling the family, the child and the family, you are important. I am taking your concerns seriously, and we are going to, it's like Maslow's hierarchy, right? You try to address those basic needs, whether it's clothing, gift cards. For us in Long Beach, we provided a lot of services and resources ourselves within the agency, multicultural events, holiday events, providing back to school, gift cards. You know, these kinds of things then really fortify engagement and fortify our efforts through treatment to prevent further maltreatment, because then families have a good experience and they're more likely then to reach out to treatment agencies in the community when something occurs or they need support. So, and then let me talk just a few minutes about assessment, because I also feel, and it's certainly a part of our model, but within this field, in terms of whether you are doing an EBT or you're providing short-term interventions of more of sort of affect regulation focused, as opposed to really getting into trauma processing, whatever the orientation. Today, or just the first time this is I think somebody needs to mute. Treatment based on trauma-specific assessment can better identify then client-specific goals. You can really customize then your interventions while also following a particular, whether it's a manualized approach or, you know, with a lot of approaches, it can be the case that through this assessment process, you're prioritizing those treatment goals that are going to be most relevant to a particular client. And you can also, through these assessments, evaluate progress, update treatment goals, and determine the appropriate time for termination. And also, I would have to say that as we provide specific interventions that are customized for our clients, also within a structured framework, such as ITCT, Real Heroes, ARC, complex trauma approaches that allow more for that flexibility, it also is the case that you are demonstrating empathic attunement in really meeting the client where they're at. So in addition, I want to say treatment includes social activism, anti-racism, cultural humility. I think it is our responsibility as clinicians to really, within whatever treatment framework we're using, to focus on cultural identity for our clients and their experiences, and understanding the perspectives of clients from diverse cultures. For example, in Long Beach, our community identified the Cambodian community as a community that we really wanted to collaborate with. And in fact, in Long Beach, it's the largest community of Cambodian folks outside of Cambodia. So there was a lot of collaboration in the community, perhaps not necessarily providing treatment ourselves to those folks, since we didn't have a Cambodian, a clinician who could speak the same language, but we supported, provided training, consultation. But also, I think, as much as is humanly possible, it's critical to have staff, volunteers, office support staff, all representing the diverse cultures of your community and the cultures that your clients present with, so that they can feel that sense of belonging, and you are really increasing the access for underserved and marginalized clients, which of course is part of the mission of the National Child Traumatic Stress Network, of which I've been a part of since it began in 2001, and was fortunate enough to receive funding a number of times from SAMHSA for that initiative. And of course, I'll provide more resources that are available through NCTSN and the website at the end. So contextual aspects of trauma exposure include early onset. We know that for complex trauma, for example, that it is often the case that maltreatment, disengaged parenting occurred early on. It's frequent and extended, ubiquitous. Sometimes these kids are also living in very unsafe communities. And of course, there's a relational context. Then in terms of trauma exposure being further compounded with social marginalization that includes poverty, fear of deportation. We've done a lot of work over the years with programs at the border that had provided shelter for unaccompanied minors coming in from Mexico and Central America, and really helping therapists in short-term settings in many cases, but not always, with kids who not only were presenting with a lot of trauma from their home country, but also as they were in transit, and then being in the US and being fearful of deportation. And of course, as we know, not so long ago, families undergoing horrible traumatic separations, which from family members as they enter the country. So these are things that are also needing to be considered when we think about maltreatment, not only what has occurred vis-a-vis child abuse or intimate partner violence, but also community violence, and also systemic violence and systemic racism. Social discrimination, race, ethnicity, sexual orientation, gender identity are all areas where marginalization can occur. And it behooves us as people working, having a commitment to really preventing the long-term effects that we see occurring as kids get older, really intervening as soon as we can and providing the necessary services that also incorporate a view to really addressing these ways in which they've been marginalized. So again, taking this further and thinking about how we need to increase access to treatment, and this may be addressed in the next more policy-oriented presentation for this series, we need to think about that although trauma, especially in the context of social deprivation, is a huge source of psychological disturbance, and I'll get into the specific long-term effects shortly. We know that 75 to 80% of children and youth in need of mental health services do not receive them. So as compared to white children, racial minority children are less likely to receive mental health services. And 85% of children and youth in need of mental health services in the child welfare system do not receive them. And so although it may feel like, we've got a long waiting list and we're well known in the community, think about ways in which you might increase the access for clients, especially those who are kids of color coming from families that have been marginalized, discriminated against, or feel that they can't turn to these white middle-class organizations. That's why the diversity within organizations that matches your community is so important, so that clients can feel welcome and not intimidated or not disenfranchised. And certainly through COVID, we also noticed a lot of gaps. We are encountering through our consultation calls that we do to follow up trainings on ITCT, that a lot of clinicians are saying that the work is just too difficult and may not be managing the teletherapy aspect, or their agencies are not supportive, or the funding has ended. So we are still encountering a lot of those challenges. And of course, we need to think about poverty and social marginalization. 38% of children in the US live in poor or near poor households, with 17% below the poverty line. In Long Beach, that was one of the challenges that we dealt with in developing our complex trauma treatment model there. The level of poverty was even higher than 17%. I think at that time, 10 years ago, it was in the lower 20s. But we really also need to then think about ways that we can address those issues. And of course, in LA, as well as throughout California, but certainly in the urban areas, we have a big issue of families being unhoused, which also contributes to a sense of marginalization and not being taken care of. And we also find Latino children comprise the largest share. These are national statistics from the National Center for Children in Poverty. So 36% of families that are living with poverty are Latino or Latinx. Black, Native American, and Latino children are disproportionately poor. Trauma rates for marginalized children, we know in child welfare, the trauma rates are very high. And again, I think if we were to look at even more recent statistics, these were within the last 10 years, but even post-pandemic, these rates would be higher. So trauma rates certainly can go up to 90% for those kids who are involved in the juvenile justice system. In high crime neighborhoods, it's also very high, 83 to 91%. And then in the community mental health system, again, trauma is very high. So trauma is definitely, we can no longer say, oh, well, just, now that that child has disclosed maltreatment, they'll be referred to that agency over there that specializes. No, we're all doing the work and we all need to address these things. So then when we think about racism, sexism, anti-LGBTQ plus behaviors, poverty, ways in which kids are marginalized, we need to think about macroaggressions, microaggressions. Certainly, these issues have become front and center for all of us. They've always been there, but have become more visible, and programs now are really focused on addressing these inequities and ways in which we can reduce racism for our clients. And that means giving them skills also so that they can go about their lives in safer ways. And thinking about multi-generational trauma, again, that's why our orientation is really to work with caregivers as much as possible and with the families. And thinking about discrimination and social maltreatment as trauma, that we're not confined to a DSM-5 definition of PTSD, anxiety, depression, substance abuse, alienation, distress. All of these things can arise with discrimination, social maltreatment, and certainly with kids encountering the kind of discrimination that they are when they are identifying as trans or non-binary. We really need to think about these ways in which kids are further may become suicidal because of the bullying that they are encountering or the systemic discrimination that they are encountering in institutions. So just because a client is talking about PTSD associated with these forms of discrimination doesn't make it wrong. Obviously, that their symptoms or behaviors can be very logical outcomes for very pathological discriminatory treatment. And these social maltreatment effects can be addressed in therapy, as are other forms of trauma. This was a study that is, I think actually now it's in press, that shows that the number of types of social maltreatment, including sexism, racism, anti-LGBTQ plus, can exponentially contribute to the mean post-traumatic stress score. So no surprise there, but as clients encounter more types of social maltreatment, which again, I am advocating for those impacts to be addressed in therapy in such a way that a client really can bring these experiences to therapy so that they can explore, process those traumatic effects, just as they can process child abuse or parental disengagement, neglect, other ways in which they are being maltreated. That these are also core issues that need to be incorporated into treatment. So, and this comes from a CAC in Oregon. I think it's a lovely reminder how we interact can add to the adversity and trauma a child experiences, or can create opportunities for care and thriving. In addition, and this is a slide shared by University of Missouri St. Louis Children's Advocacy Services, really looking at all the ways in which we can fortify our kids and families' healing and recovery through really fortifying the community. And that's where collaborative relationships come into being. We have after-school programs that are safe and supportive. We provide the kind of advocacy that really says to a child and family, we care about you, affordable housing, all the things that I've mentioned that are so important in the healing and recovery for our kids. So when we think about complex trauma, as I mentioned, this is sort of a quick whirlwind tour of complex trauma, given the time frame that we have today, that we're noting with our clients, did the occurrences begin early on in their childhood? Have they been repetitive? Have they been relational in that we've always known, or for some time, the past 30 years, right, that closer the relationship, the higher the likelihood of greater trauma, in that there's a sense of betrayal of trust, and this person may be someone that you are encountering on a regular basis and maybe a family member. So that relational aspect is also part of complex trauma. Acts of commission, meaning things that have been done to kids that include sexual, physical, psychological, emotional abuse, but also acts of omission, the disattunement that I've mentioned, neglect, non-support, disengagement, and of course, re-victimization is also something that we need to be concerned about, as we know that if a child has been sexually abused before the age of 13, there is a higher likelihood of being victimized in the future, not only through sexual assault, but other ways of being abused. Okay, so when we think about complex trauma, it's multi-layered, and if we are able to address these very complicated situations, then I just want to cover some points that we need to be considering as we think about our interventions. That with complex trauma, there can be multiple sources of abuse and neglect, often in the presence of attachment disruption and likely to have begun at an early age. So we're not going to, with complex trauma, just focus on one particular incident or the incident that, say, brought the child or adolescent into treatment, but we're really going to be evaluating and assessing multiple sources. And the symptoms include affect dysregulation, attachment, relational insecurity, dissociative reactions, risky behavior, self-harm, suicidality, requiring multiple treatment modalities and interventions at a system, at an individual and system level, thinking about caretakers, collaborative agencies, schools, other ways that we can intervene so that we're not just confining our treatment to an individual hour with a client. Effective interventions address social inequities, as I mentioned, systems, as well as trauma impacts beyond cognitive therapy or therapy exposure. This is taken from some of John's work, again, looking at early childhood maltreatment or disattunement, then leading to painful implicit memories and attachment disturbance. So it can be the case that kids are maltreated pre-verbally so that they do not have those memories encoded verbally, and therefore they're not explicit, they're implicit, but then they are manifested through attachment disturbance, through behavioral dysregulation, reduced emotional regulation skills. And then we also see disturbance in self-organization, self-capacities, beyond classic post-traumatic stress symptoms, then leading to complex post-traumatic stress, and sometimes, we'll identify these outcomes as being more of a personality disorders, especially with young adults and older, or even older adolescents. But I would just invite you to think about the trauma lens instead of rushing to a diagnosis. I think the next slide deals with, or this slide deals with, common diagnoses from PTSD, complex PTSD, which I've mentioned, through impulse control disorder, borderline personality for older adolescents. Just, think about, before you rush to a diagnosis of ADHD or conduct disorder in a younger kid, or borderline with an older adolescent, think about the traumatic exposures, acts of commission and acts of omission that client may have experienced, as well as dysregulation that arises out of attachment insecurity. John has written extensively on distress reduction behaviors, including self-injurious behavior, compulsive sexual behavior, bulimia, aggression, impulsive suicidal behavior that we can see and we do see in adolescents and young adults, but also anxiety, depression, anger, very common, post-traumatic stress, emotional dysregulation, as I mentioned, negative relational self-schema, substance abuse, and dissociation. So I'm going to, skip over this pretty quickly because I'm sure that most of you are familiar with the concepts of, if a child is coming to you following a forensic interview, that maybe you have more latitude in terms of the details of the exposure that you are evaluating, but you also want to work at the patient's pace. And I've had kids say, oh, I already told, Detective Brown, I don't need to talk about it now. So it may be the case that you titrate that exposure, you titrate you're asking direct questions, you're using direct inquiry, but you're also going at the client's pace so that they are not so dysregulated that they don't want to come back. And if they don't come back, you can't really continue to provide the treatment that could really help them in their healing. Information may be gathered then over the course of treatment. And so think about, how have others responded to the disclosure of the abuse? Of course, what are the symptoms, risk and safety factors? And then also a timeline can be constructed for each of these trauma exposures that they may have experienced. These are all the different assessment areas that we're all involved in looking at when we're evaluating kids for treatment. Not only behavioral observations, mental status exam, but thinking about their risky behavior, social functioning, academic, developmental, the caregiver that comes in, are they able to report clearly developmental milestones, or is that kind of vague information? They're not really aware of those milestones. These are things that can help you to really formulate and analyze the situation that your client is dealing with. And I know I have a lot more on assessment here, but I'm going to skip through to, before we're doing trauma processing work, we really want to help kids to increase their resilience, and whereby then they have the coping strategies to be able to do the trauma processing work. This is a whole half-day workshop. So again, my apologies for, the brevity of the discussion. But we want to think about mindfulness, metacognitive awareness, even with younger kids, really helping them to slow down their breath, to understand that feelings and thoughts that they have are just thoughts, not facts, but that they can be explored without judgment, with acceptance, and again, through a strong therapeutic relationship. John has also developed in ITCT Regain, which is an expansion of RAIN, developed by Tara Brock and others, Jack Cornfield, which again is a way for kids to be able to bring down the dysregulation such that they're able to identify triggers, they're able to do trauma processing work, which is integral to this work. And also, we want to think about ways that we can fortify that sense of self. For kids who have been traumatized, they have an other orientation. Their treatment, as we see it, is a process of really encouraging kids to become more aware of their internal states, to trust their own truths and their perceptions, to become self-aware rather than just hanging on, just having that survivor mentality, but really being able to think beyond that, to become resilient in that if they encounter further maltreatment, racism, discrimination, or child abuse or partner violence, they are able to get the kind of help that they need, that they have those coping strategies. So the therapist is avoiding overuse of interpretation, lecturing, and over-reliance on psychoeducation, if you will, but really, again, meeting the client where they're at, which really then reinforces that sense of attunement. And so over time, then the client increasingly comes to value their own perspectives. And caretakers are also involved in that. And then that sense of self and having a positive sense of self and identity also can counteract some of those social messages that kids are encountering that reflect racism, sexism, homophobia, and harsh cultural judgments that also can be seen as abusive or traumatic. So the therapist is supporting that sense of self-determination with the family. Obviously, with a younger child, it's going to be more the case that you're going to focus on the family system, but it is still possible, even with the little ones, to help them to really trust themselves and to be able to express those feelings and experiences with a helper who can then intervene and hopefully prevent further maltreatment. And the next part of this is addressing attachment and relational processing to address previous relational-based trauma and facilitate healthier relationships. We know that attachment history is central to the development of complex trauma, that attachment systems contribute to how we respond to loss or trauma, and attachment relationships can become more secure, as I've described, through therapy and with longer term treatment. But even within, if you only get to see a kid or a family once and then they never return again, even just having that experience of being listened to, even on one occasion by a helper, by a professional, can truly change a child's life. So we need to, give ourselves a break when we feel frustrated that we're not able to continue with a particular client that we have already, just by virtue of being there and being attuned, that has forever changed a child's life. And we're really trying to address further trauma by really incorporating into our work this relational aspect of trauma processing. And clients with more secure attachments can better process trauma and self-regulate. This is just a slide summarizing the different attachment styles. Generally, and we do see kids who do have a secure attachment with a caregiver or have had that experience. So that's not to say that we're only seeing insecure attachments, but certainly disorganized attachment, I think, is one of the most challenging and usually occurs when there has been a great deal of violence and basically no one has been available to provide empathic attunement to that particular child. Another study done by Briere and colleagues showed that exposure to and I would invite you to look this up, and I have included these references that I'm mentioning at the end of the slides. Exposure to disengaged parenting may be especially detrimental, both by increasing the risk of child abuse and by virtue of its impacts on attachment and security. So that circumstance where you're seeing a child and adolescent who's reporting sexual abuse, say by a family member, but also there has been neglect and lack of emotional support. It may be the case that they're able to talk about the actual acts of commission, but they're not able to address how that primary caretaker was disengaged or really dismissive, avoidant in their parenting style. So, and then thinking about caretakers, we want to increase caretaker understanding of trauma and trauma responses, provide them with emotional support, provide an opportunity for them to explore their own traumas and impacts, increase their parenting skills, facilitate and improve communication. These are all strategies for preventing further maltreatment, while also providing a forum, a context for caretakers to address their own traumatic exposures and perhaps refer them to an individual therapist or group modality whereby they can get their issues addressed as well. For example, at Stewart House, we did a lot of work with caretakers whose partners had sexually abused their children. And I'll show you a protocol in a minute. So, but we also want to think about caretaker antipathy, is caretaker involvement, and I would include foster parents in this. Caretakers maybe who may be more transient, or it's more of a short-term placement. Still, if you can address some of those parenting issues with them, such that the child is feeling safe enough to be able to process more of their trauma, it makes a big difference. And youth may sometimes express a feeling that they do not want the family involved, especially older adolescents, or they may be emancipated or unhoused. So collateral sessions to support the caretaker, provide education, address parenting skills, relational process. The work may in fact parallel what you're doing individually with their child, but the child or the adolescent is really the primary focus for treatment. But you want to incorporate as much as possible interventions which will help the kid receive better parenting and for the system to be more supportive. So trauma processing of triggers for the caretakers, very important work, and caretaker groups, individual therapy, parenting classes. Here's a protocol for caretaker group that we developed over the years, involving 12 sessions. So you can look at how the individual sessions from these sources. This comes from the adolescent version of integrative treatment of complex trauma. And you focus on the caretaker's own trauma narratives in 2 of the sessions. Sometimes you want to modify the order of the sessions, but I would say that caretaker groups can be hugely, super significantly helpful in your work and make your work easier. And you can kind of share the interventions with the peers who are there also to provide support for clients who may be more receptive to what their peers are saying as opposed to the therapist. And then, of course, family therapy. We have a module of 6 sessions, but this can be done using obviously other approaches to addressing family systems. But these are some of the core concepts, in that you want to begin by assessing the current functioning of the family, what their experiences have been vis-a-vis the traumatic exposures that the family has had. I'm thinking of a case where a child was hit by a car while running across the street to get onto the school bus. Family was there, witnessed it, as well as sibling and parents, but they all had different experiences. The child survived, who was hit by the car, but was in the hospital for an extended period of time. So we were providing trauma-focused services for them. And then it turned out that there were instances also of child abuse and neglect that had preceded this particular traumatic event. So there were many layers, but the family members all had different accounts. And so they were able to do individual timelines and then share with each other their experiences directly with regard to the trauma that they had experienced, the thoughts and feelings, the fears, the anger, et cetera, that came up within the family context, which also was complementary to the individual therapy and the couples therapy, actually, that was done with the parents. So now I want to talk a little bit about self-care, because if we are doing this work, we also need to be thoroughly mindful of our needs as clinicians. How can we be effective in this work and take as good a care as possible, given all the challenges and all the ways that we are stressed within organizations. Sometimes It's the organization or the politics of a situation that are much more traumatizing for clinicians than the actual work with the kids and families that we see. Whatever the source of stress might be for you, or maybe you're highly triggered with certain children or adolescents that are presenting with, say, trauma exposures that are reminiscent of the trauma exposures that you have had in your life, that it's really important that we think about using state-of-the-art evidence-based treatments that allow the use of the therapeutic relationship as a grounding, stabilizing force, that we think about the development of emotional regulation skills and the processing, obviously, of painful attachment and trauma memories, such that through that processing, the memories are still there, but they're less traumatizing for the client. But as we do this work, we're capitalizing on this therapeutic process to increase our own mindfulness and compassion skills, insights, decrease our reactivity and countertransfer, and grow as a therapist and as a person. And this slide just, summarizes the various ways in which we can take care of yourselves. In our writing, we devote a lot of time and attention to wellness. And in the future, we hope to compile revised materials, updated materials for ITCT to address younger children and also adolescents within one volume, but really devoting a whole section to clinician wellness. I think, as I mentioned during the pandemic, therapists were particularly challenged, but also after the lockdowns ended and we were doing the work again, we were also and continue to see families who are sharing that even more trauma occurred that went unnoticed or was not addressed during that time of lockdowns. We're still recovering, I think, from all of that. So it's really important to address our own needs as clinicians, to think about our own reactions with self-compassion, to think about how we may be overly involved with clients, or we're more avoidant, or maybe feeling judgmental. I think sometimes when caretakers are demonstrating through their parenting the impacts of their own trauma, and that's impacting our child client, sometimes we can be very distressed by the caretaker's behavior, and we need to take a step back. And I think it also helps to work with adult clients who are trauma survivors in individual therapy, whether it's in a private practice or within your own agency, so that you can have that understanding and compassion that multi-generational trauma is a very real thing. And using Regain, as I mentioned earlier with clients, we can also use that ourselves to ground ourselves, that we recognize the feeling that is being triggered within the work. We can ground ourselves, and while we accept or allow these feelings to come up, we can explore, oh, that has to do with losing my grandmother in a very traumatic way when I was 6 years old, and she was my primary caregiver, whatever it might be. And then eventually being able to non-identify and let that feeling go so that it's not so overwhelming. Certainly having a balance within our workday, taking vacations. I'm a strong believer in having creativity in your life. I wrote and published a novel, which has been a great source of enjoyment for me. Sort of branching out into fiction has been great fun. Having time with family and friends, traveling, being an activist yourself, taking up a new instrument, learning a new language, taking retreats for yourself. And I'm also a big fan of using humor, taking the work very seriously, but also enjoying our clients with fun. And certainly I could spend a lot of time talking about that and how, especially through play therapy and artwork and other expressive tools, we can have fun with our clients, and they can enjoy the process as much as it can be difficult and painful. And certainly getting collegial support, supervision is a great source of support, but also peer supervision, reaching out to colleagues, being a part of organizations like ABSAC, really important for us professionally to feel that validation and support. So here are a few additional slides providing links for the National Child Traumatic Stress Network, complex trauma, fact sheets, a resource guide that can be used for youth that was developed from the complex trauma work group in the National Child Traumatic Stress Network, developmental trauma disorder. The University of Connecticut has had a center and currently is a Category 2 center of the network. Develops wonderful, there's a whole treasure trove of videos available at the NCTSN website where I think they're archived, and you can also, if you're licensed, you can get CEUs, but they're demonstrations of critical moments, stressful moments in therapy, enacted by child actors, adult actors representing families, and real therapists. So I would also direct your attention to these sources, which are really interesting, inspiring, and can give you ideas for your own work. Then there are a number of videos that I have used in trainings, but also with clients. Never Give Up, which is a complex trauma film by youth for youth, remembering trauma, also an excellent film. Some of the evidence-based treatment models for complex trauma that are listed at NCTSN, including attachment regulation and competency, or ARC, TST, trauma systems, therapy, ITCTA that I've mentioned, and ITCTC, Sparks, Target A, Real Life Heroes. And here's another slide providing other references and resources to, at your leisure, look into as other sources of treatment interventions that can really provide that level of prevention for future maltreatment that we've been talking about today. And then a number of slides providing references. And now let's go to a few questions. I think we have a few minutes. There are questions in the chat box. Let's see.
Yes. Let's see. And thank you, Amber, for putting Dr. Lanktree's email and contact information in the chat. If there are any questions, I know there is one comment. Going back earlier, it was a bit earlier in your presentation, but Gwen shared that I think it's also important when addressing the issues such as racism, that mental health professionals be equally aware of how the field has been part of creating and perpetuating those, as it is for them to be aware of ways to approach change and healing. She also shared a resource in the chat as well that you can download.
Wonderful.
Does anyone else have questions
yeah,
or comments?
very important. And that's the systemic racism that I was mentioning earlier, and that it's so important for us as clinicians being part of the system, and particularly if we're part of the white middle class majority, that we really make the effort to learn to educate ourselves as much as possible, but really approach this work with cultural humility. And certainly institutions and organizations have perpetuated this kind of discrimination and sexism, for sure.
I think with that is perfect on timing. Again, thank you all so much for joining. You will receive a copy of the recording and a copy of the slides. And again, Dr. Lanktree's email is in the chat if you have any questions. We hope to see you at the next next session next week. And of course, the colloquium in June. Thank you all so much. Have a wonderful day.
Thanks, everyone. Take care. Be well. Thank you.